the slide again. Okay, and in addition to the basic anatomy just now, it was made stronger by this structure. Okay, it's seated to the humerus. Okay, there is a rotator crescent, as you can see here, which is formed by the distal portion of the spartanatus fiber, and then the rotator cable, which is formed by the coracohumeral ligament. So this structure adds on to the stability and strength of the rotator cuff. Okay, on top of the rotator, there's a rotator interval. Okay, it's covered by strong coracohumeral ligament, so it provides more stability and more strength to the shoulder. Okay, a bit more on the rotator cuff footprint. So basically, all of the muscle have different footprint. So you can see here on top here, there's a supraspinatus muscle, the intraspinatus muscle, it's at a different place, and you got the subscapularis as well. So the etiology is different for younger patient and older patient. For younger patient, usually it's because of trauma, because to overuse due to overheat activities such as playing badminton, playing volleyball, tennis, playing any throwing activities, right? And for other patient, it's usually due to, one is when the muscle become weak, all right? The strength reduced. Okay, and if they
recording in progress.
If there is impingement at the subacromial space and tearing with advancement in disease, all right? So it's not just a disease, it's a continuum of disease. It has these different ways. Start from mild, become severe. First, impingement, such as the part of subacromium and subclavicle. Then, after there's inflammation, the tendon itself become calcified. When it become calcified, become hardened, and extra movement, any excessive movement will cause tear. And if the bone is affected because of the degeneration process, because rotator cuff arthropathy, osteoarthritis of the shoulder, and then after that is pseudoparalysis, where the patient cannot move the shoulder at all. Okay, classification. There's a lot of classification. We usually classify the tear by size. It's small. In MRI, you can see it's less than 1 cm. Medium, 1 to 3 cm. Large, 3 to 5, and massive, more than 5 cm. Okay, this is about the same. Okay, and we also classify this is more on intraoperative, where it's a crescent shape, where it's a reverse L shape, U shape, or contracted shape. This is when we do scope. When we do scope, and we can see the pattern, the shoulder, and to see the severity. Okay, because when the patient presented late, we use this classification on MRI, so we can see the degree of fat generation in the muscle. So as you can see here, the first stage, the fat is less than muscle. Okay, stage 2, fat most predominantly big, but muscle is small. Okay, and this stage fat is around the same with muscle, and here where the muscle has degenerated so much, the fat has replaced all the muscle, almost all of the muscle. Okay, symptoms. So patient, if in acute setting, can come with acute pain. There's painful range of motion, such as overhead activities, pain over the shoulder region, and if the patient come late, presented late, patient present with stiffness, muscle weakness, atrophy, and of course, there's a functional daily impairments. So this is a bit of specific tests. Besides, we do general screening, we look for inspection. When there is atrophy, we check for any tenderness, we check for range of motion. Okay, but this is the specific test for each muscle. For spinatus, we do empty can test. Okay, this one you can explore. You can Google or you can YouTube. How do we do the test? Okay, also by our department, Mr. Garizam previously has put in YouTube how to properly examine the shoulder and test each set of muscle in the YouTube. Okay, yeah, against spinatus, we can do the empty can test and drop arm test. So subscap, usually we do a belly press test. Teres minor, usually we do hornblower, but not so often because usually can cause pain to the patient. And for infraspinatus, we external leg test. Okay, what we can do when the patient come to our clinic or emergency department. Okay, after we have assess, we take the history, we took the did the physical examination, we can do X-ray. Okay, all right. So in X-ray, if in acute setting, let's say in a young patient, okay, young patient usually there is nothing much because the soft tissue is involved. Okay, but somehow if the patient is an old patient, what you can see, maybe there's a calcification, maybe there's a burn spur or glomerular arthritis, right? And the coracohumeral distance, basically the head has shifted upwards, all right? So because of the weakness of the contracture, of the stiffness of the rotator cuff. Okay, then for the next modalities is MRI. So it's a gold standard. It can detect tears and inflammation. We can determine size, so we can classify for them. And ultrasound is not done often. Okay, management. If there's a partial spinatus or infraspinatus tear, if the asymptomatic full thickness is as the patient got no pain, if patient is too elderly, if the operation will cause more harm, or patient is non-compliant, patient will not adhere to rehab process after the operation, usually we plan for conservative treatment for the patient. All right. For operative, usually is into subscap tear. It can be due to symptomatic full thickness, spinatus or infraspinatus tear. And if there is no improvement after 6 months of conservative treatment, we can opt the patient for suggest patient for operative treatment. So what is the conservative management in general? It is for we mandate the patient for physical therapy. Give the analgesics such as NSAIDs, and the physical therapy usually focus on deltoid deconditioning, shoulder abduction, prescapular strengthening. Okay, because this muscle is not a rotator cuff, but it's a secondary shoulder stabilizer, so it adds more to the stability. Okay. For surgical repair, it's a bit complex. However, for low-grade partial tear, all right, so they say this less than 2 centimeter, less than 3 centimeter, grade 1, grade 2. What we can do is we debride, we do the subacromial decompression, okay, by doing a arthroscopy, scope by scope. All right, but after the operation, we can ask the patient to go to physiotherapy, give analgesics. If a high-grade partial tear or complete tear, okay, we can do a repair. Okay, and if there's a massive tear which is irreparable, we can do tendon transfer. Can be done, is done here, and we can do a reverse total arthroplasty. So for arthroscopic repair, okay, usually what we do is long head bicep tendon repair, which is a tenotomy, BS tendinosis, okay, tenotomy, and then the footprint restoration, which is a double row, BS row. I show you the picture next after this. Okay. So arthroscopic repair, the aim is to make it, see from the here, there's a massive tear, the U-shaped tear, we repair it back. Okay. And then this one is the anterior interval slide. Basically, you add on more stability. This one a bit complex. It release the spinatus from the rotator interval and it basically modify a bit. Shift it to the lateral footprint. Okay, this is the technique, which is the single row vs double row. Double row basically is more strong. Okay, this is done by arthroscopic technique, and the functional, our study has showed that double row technique is better, has better outcome compared to single row. However, double row is more difficult to perform. And for irreparable tear, which is massive tear, okay, you can do the option is tendon transfer, such as a lower trapezius tendon, latissimus dorsi, or plaque major. Okay, this one is a bit. This is the lower trap. This is how they mark pre-operatively. Okay, this is how they open and they transfer the muscle to the rotator cuff. Okay, if the X-ray shows arthropathy, which is osteoarthritis, you know this is an advanced disease, so the rotator cuff itself has become atrophied because of the progression of the disease. Okay, but patient complain of pain. Okay, so what we can offer the patient is we just do a reverse total shoulder arthroplasty. And this one. So, however, because rotator cuff has already gone, the muscle has already gone function. So it depends on the deltoid muscle. Okay, so the movement is more on adduction, and this is to reduce the pain. All right. However, this procedure itself, it doesn't what's called gain back the function of the cuff, just to reduce the pain. Okay, retain a bit of range of motion by the deltoid fiber, which is adduction. Okay, what is the implication on ibadah? First, I'm not an expert on this, but I think most of the patients that come in specific ibadah, okay, the problem is in ablution, taking ablution, and salah. Okay, so I just need a hadith, okay, noted by Atta bin Yasar. Ibn Abbas performed ablution, wash his face in the following week. Okay, he let it out of a handful of water, rinse his mouth and wash his nose with it, put it in water, then roll it out. He then took another handful of water and joining both hands and wash his face, took another handful of water, wash his right forearm. He again took another handful of water, wash his left forearm, pass over wet hand over his head, took another handful of water, put it over right foot up to his ankle, wash it thoroughly, and similarly took another handful of water, washed thoroughly his left foot up to the ankle and said, I saw Allah Apostle performing ablution this way. So as you can see, the action of taking ablution itself, it involves a lot of overhead activity. You need to wash your nose, you need to wash your face, you need to wash your ear, you need to wash your hair. Okay, so if the both shoulder is affected, it affects the patient in such a way because patient get pain, patient get weakness. If it's in chronic disease, patient has weakness, patient has difficulty in lifting up the hands above the
kita tekah sendiri.
Okay. Okay. So in a second issue is from this is hadis Dr. Abdul Wafi.
Naik attend dulu.
Allah took for the prayer. He used to raise both his hands up to shoulders, used to say or saying the takbir for going and raising his from it, and used to say Sami Allah and Hamidah, but he not do that in position. So basically in Salat itself, the starting of prayer, which is Takbiratul Ikram, and every each set of takbir from ruku, come back to we did the takbir again, and when we do the sujud, and we want to sit back, we have to push. Sometimes most of the patient push it back. Patient will complain of pain. All right. Okay. And other activities, because our daily activities itself is a ibadah. If the niat is lillahi ta'ala. If our intention is lillahi ta'ala, everyday activities become an ibadah. So when patient want to do sport, riadah activity, they cannot do the sport activity that they love and used to. Okay, if you want to take shower, okay, and they want to do anything, all right. So it has implication on daily activities. All right. So the take-home message from my slides, basically, when patient come, we complain of shoulder pain without any acute fracture, without no fracture, no history of trauma, but usually because of the overhead activity, because of sport activity, or because of what I say, long chronic disease in old people. So it must take into account, must examine properly. Okay, because if you miss the diagnosis, if you say, because most of the doctor or houseman, they address this one as a adhesive capsulitis or frozen shoulder, and they didn't look properly into the problem, and patient will left with after years and years, patient will left with deformity, or not deformity, patient will left with chronic pain, and it affected their lives so much. They cannot perform solah properly, they cannot perform ablution properly, and it affect the daily activities. Yeah, if you don't properly examine, so the effect on their life is so devastating. Okay, so I will pass the baton to our moderator for this time. If any question, you can ask during the question session. Thank you.
Okay. Thank you very much for the informative talk, Mr. Wafi. Just a public announcement. For those who join in the Zoom session during halfway the talk, kindly please check your mic and mute it during the conference. Thank you very much. So now we will proceed with a question and answer session. Feel free to ask if you have any doubt regarding the topic. And the mic is, you can now unmute your mic and ask the question. Otherwise, if you have questions in between the talks and would like to ask the speaker, you can raise the question in the chat box, and we will answer your question after the talk. Is there anyone have any question regarding the previous topic of rotator cuff injury and the difficulty in Salat? All right, okay. I have one question from the floor, Mr. Wafi.
Yes, what is the
Okay,
question?
okay. How long the patient need to be immobilized after a rotator cuff repair? And also, normally, how long will the patient have to wait or can expect to return back to the activity of daily living or normal recreational sports activity after a rotator cuff repair is done for the patient?
Okay, in general, for any soft tissue, ligament, tendon, it took 6 weeks to heal it by itself. Okay, we did the repair, but for healing purposes, 6 weeks. But we then mandate the patient to rehab, okay, to strengthen back the muscle and everything. So usually in study showed that around 6 months, patient can go back to sport activity if there is no residual pain. All right, but it can last up until 1 year. It depends on the patient compliance. That's why patient compliance is very important in patient selection process. I hope that answers your question.
Okay, thank you very much, Mr. Wafi. Yeah, that's very clear. Okay, any more questions from the other participants? Okay, so we will proceed to the second talk. But if you have doubt or any questions regarding the first topic, you can put it in the chat box, and we will answer after the second talk. Okay, as for the second talk for this morning, it will be delivered by Associate Professor Dr. Ibrahim